specifically like to, by the way, in terms of the papers, would you like me to give you, is one copy of each enough, or would you, in terms of the papers, one other thing. I was speaking with, in my personal patients, actually 2 points before I go to the papers, I was speaking with one of the infectious disease doctors who practiced early on in the 80s and 90s, and he told me 2 things. He told me, one, in his experience, when they compared Marinol with smoked marijuana, that the AIDS patients that he has treated do not have anywhere near the benefit in able to get a normal appetite with the marijuana as compared with the Marinol. And one of the papers specifically looked at that I'll be referencing. Secondly, in my own experience, for my patients who have illegally, and I obviously can't say which patients they are because of confidentiality, but in my patients who have confided in me, and if a couple dozen over 20 years have confided in me, it's probably 10 times that who have actually done it, have confided in me that they've used medical marijuana and that they were significantly able to decrease their use. Now, again, I agree that that is anecdotal, but it is very powerful anecdotes when you're looking in the patient's eyes and you see the suffering that they have when they are on regular pain medication and they're begging you for something to relieve the medication, and all you can say is, we can sedate you enough so that you don't care that you're in pain. And that's basically the current state of treatment with a lot of the neuropathic pains. There was a study that was done that basically showed, this was a study done in patients who were HIV and with antiretroviral therapy, and it was by Bork et al. Actually, Bork de Jong et al. And it was from 2005, and basically showed that patients on smoking marijuana were much better able to adhere to their pharmaceutical regimen. Again, this is pretty much the same thing that in patients with hepatitis C. This is by Sylvester et al. From 2005, and this basically showed that patients were much better able to tolerate their hepatitis antiviral medications against hepatitis C. There's another paper by Haney et al. From 2007 that again clearly shows that it's effective in patients who, in order for them to be able to tolerate it. Now I'm going to get into some of the neuropathic papers, and there was a paper by Ellis in 2008 that showed that what they did was they did a cannabis crossover study in which versus placebo, and they basically showed that neuropathic pain was able to be controlled in these patients with HIV peripheral neuropathy. I fortunately have not treated any HIV patients with peripheral neuropathy, but there's another study. Actually, I'm sorry, this is two of the same. And I'm just listing these studies now for the record because I know you all have copies of them rather than going into all the micro details of them. But I think one of the best studies was a study that actually looked at state-run clinical trials. And this is a paper by Musty and Rossi, published in 2001. And they basically looked at six states. They looked at least 6 states. And in every single state, they compared Marinol with smoked marijuana. And they found that the Marinol did not have the effect. In one specific, in Texas, which was the worst state, and I am cherry picking, giving you the worst, obviously, there was a 40% improvement in symptoms on the patients who were taking Marinol, and there was a 90% improvement in symptoms that were smoking marijuana. Now, obviously, there's a lot of variability because what I understand from people who tell me who do smoke marijuana, there's a big difference in the effect that you have. By the way, I just want to talk about that. There was a study, and I'll get it and make sure that you have it, in which they looked at the LD50 of marijuana, and they found that it was 10,000 times higher than the dose that, this was in rats that they did it. They found it was 10,000 times higher than the dose that you would need to get high, not higher, to get high. And so the safety profile, most of the narcotics that we prescribe have an LD50 that's in the range of 5 to 20 times higher than the dose that people are taking. So you're talking 10,000 times higher for an LD50. We're talking about much better. There was actually a study that came out, and I don't have the actual study, but I saw it on the news feed just this week from, I believe it was the University of Texas, and it was a 3-level study. It was a very large study. It just got published this week, and I'll be getting the data for you, the actual study for you. And in this study from the news feed, what I gathered from it was they basically found that most of the pain receptors and they were doing this in rats, but then they translated it to humans, and they did a test with an electric shock on the arms to see if it worked. And they were cannabinoid receptors in the spine, and they developed a cannabinoid blocker so that the cannabinoid receptors will not block the pain. And what they found was that the cannabinoid blocker was effective it was with the cannabinoid blocker that the rats and the human subjects both suffered as much pain as when they did not use the cannabinoid blocker. So obviously one of the main receptors in the spinal column is a cannabinoid-driven receptor and not a narcotic-driven receptor. So if you're going to treat a patient, you treat them with the simplest medication that you can that blocks the simplest, most peripheral receptor that you can, and that's why cannabinoids are so much safer than narcotic medications. So the bottom line, to summarize my testimony, is that I have personal experience from patients who without marijuana were basically forced to be disabled on the pain medication. Ones who confided with me with marijuana were able to function and be productive members of society. That marijuana is one of the safest pharmaceuticals that there is on the market. That smoked marijuana is much more effective than oral marijuana. And these last 2 points are both scientific findings, not this. There's a lot of paranoia because we feel that there's a criminal element out there that is dealing with marijuana. There's purely a criminal element out there because of our prohibition. In the 1920s, there was a criminal element with alcohol, and that criminal element disappeared when the prohibition against alcohol was removed. And so I really strongly ask the pharmacy board to acknowledge that marijuana is a safe, effective, smoke marijuana is a safe, effective therapeutic agent that should be in the pharmacopoeia of physicians so that we can adequately treat our patients so that they can become functional and viable members of society. I'll be happy to answer any questions that the board has.
Thank you, Doctor.